Hi, everyone. Welcome to session 118 of the Behavioral Observations podcast. You may recall that a few months back, I interviewed Dr. David Cox, and in our discussion, we spent a fair amount of time discussing the literature on the use of psychedelics for the treatment of a variety of behavioral and mental health challenges. Well, I recently got the opportunity to extend this conversation with Dr. Matthew Johnson. Matt is a professor of psychiatry and behavioral sciences at Johns Hopkins University, and he's been a leading figure in this area of research for over 15 years. Matt's expertise in this area is so well regarded that he's been sought out by major media outlets such as the New York Times, the Washington Post, the Wall Street Journal, USA Today, Chicago Tribune, the San Francisco Chronicle. I mean, I can go on and on and on. He is the media's go-to guy for anything in this area of research. He's also been featured in a special episode of The Tim Ferriss Show. And as such, I'm just a little bit more than humbled to have him here on our little podcast here. In our chat, we did a quick overview of delayed discounting. We talked about decision-making with condom usage and the behavioral economics of cannabis. As an aside, we've done quite a few shows on behavioral economics. And if you are looking for a primer of sorts, I have listed in the show notes about 4 or 5 previous episodes where we went into this stuff in quite a bit of detail. So back to this show, though. Matt and I spent a large part of our chat discussing his groundbreaking work in the area of psychedelics. We really get into the weeds, as it were, of how these studies are done and discuss everything from recruiting participants, the timing of these trips, how participants are supported through their experience, the impact of having quote-unquote bad trips, what are transformative experiences, what are the hypothesized mechanisms of actions, and what these treatments will look like in 5 years, and so much more. I really recommend listening to it the entire way through. I think we get more and more into the details of this as we go on. So we also close with a fun discussion of the concept of impulsivity. In Matt's view, he feels that this is not a useful term as a psychological construct, and we get into how he came to that conclusion. So lots of great stuff in this episode. And this episode happens to be brought to you by Behavior University. Their mission is to provide university-quality professional development to the busy behavior analyst. Learn about their CEU offerings and podcast-specific discounts at behavioruniversity.com/observations. We're also brought to you by HRIC Recruiting. Barb Voss has been placing BCBAs in permanent positions throughout the U.S. for just about a decade. And she's been in the business more generally for 30 years. She works directly with you. There's no middle person. So if you want that high level of customer service and experience on your side when you're looking for a new job, go to hricolorado.com to schedule a confidential chat right away. And then lastly, I'd like to mention something I don't bring up all that frequently. I've had this, what I call the membership program. It's not the most original name, I'll grant you that, but it's a membership program for the podcast. Think of it as like a DIY Patreon. It's been running a few years now, and it goes for the princely sum of $9 a month. Members get access to a private Facebook group where they are able to get nearly instantaneous access to the videos of these podcast interviews. The best part is that members get the raw feed. That means no ads and none of these introductory comments. You just get right to the conversation itself. Another cool thing we do is hold Zoom hangouts with former guests. And we do this about 6 times a year. I might be doing a little more frequently now that we're in quarantine. And basically, we schedule a big Zoom call. We have everyone come in, and people get to ask guests questions directly. It's quite a bit of fun. So if you'd like to learn more about that, go to behavioralobservations.com/membership. Okay, I think that's it for opening announcements. So without any further delay, please enjoy this fun and informative conversation with Dr. Matt Johnson.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Dr. Matt Johnson, thanks for joining me today on the Behavioral Observations Podcast. How you doing?
My pleasure, and I'm doing well.
I am really excited. I know we were just chatting before we hit the record button how you're a veritable podcast pro, and not just that, but you've been tapped by countless media sources, places like the New York Times and Newsweek, and oh gosh, I could go on and on. The list is, I think, has dozens and dozens of names on it. So it's an honor for you to join me here on my little corner of the internet. So thanks again. This was an introduction facilitated by our mutual acquaintance, Dr. David Cox, who was on the podcast earlier, and he gave us a little primer on the behavioral economics and some of the work that you guys are doing with psychedelics and things like that. So I thought this would be a fun opportunity to kind of extend the conversation and dig in a little bit deeper. So again, having said all that, welcome.
Thank you. Thank you. Happy to be here.
So before we get into the general subject of behavioral economics and drug and behavior interactions, let's talk a little bit about how you first got into this. I'm sure uh, as a kid in high school or middle school or something like that, I would imagine that doing experiments with psychedelics might have been something that would have been hard to picture. So how did you end up doing what falling into this line of work, and more specifically, how'd you end up getting interested in studying the interaction of drugs and behavior?
Yeah, so there were sort of multiple threads that um, eventually converged. Um, I let's see. I started out as an undergraduate as an engineering major, became sort of disillusioned with was uncertain about what direction I was headed. Took a couple of years off from school, kind of had the early midlife crisis. In that time, I had the idea of going back to school into psychology, and folks would tell me I must have some aversion to money, switching from engineering to psychology, but I did it anyway. And that was really at a time where I didn't know what behavior analysis was. I had no understanding that there even was a natural science of behavior. I didn't know anything of quantitative or empirical psychology at all. But I thought sort of you know understanding people was something that I really wanted to go into. And so during that time, though, I also I mean, this is when I was 19, 20. This is where I sort of learned a little more about the world, and read up on history, and encountered a number of interesting characters, and through that I learned about the role that psychedelics have played in our culture, um, particularly from the late 1960s, during the sort of the heyday of the psychedelic 60s, which is really the late 60s, early 70s, and the number of people across so many sectors, the arts, certainly including music, but then also um, and technology sectors, people making these really extraordinary claims about the benefits that they had seen from using psychedelics. And so when I went back into school, I really I was really fortunate to be in a department where the only two full-time professors were both behaviorists, and jumped headfirst into behavior analysis, and had the fortune of getting involved at a very small school in some drug research. So this was cocaine research in rats, and we did some of the earliest cocaine immunization work. And the work that I did was setting up drug discrimination for cocaine in rats, and then seeing if the immunization would block drug discrimination responding for cocaine, which it did. And we published that work. But so during this time, both through that and through coursework, I became incredibly interested in the effects of drugs on behavior broadly. And this is across all drug classes. The idea that any of these compounds could have such effects on the nervous system and on behavior was it's still I find myself still just astonished at the power again across compounds. Across drug classes that we can make little tweaks, these little biochemical tweaks to the nervous system by throwing something in. And you think about it, it's pretty sloppy. Throw something into the bloodstream, and a little bit of it ends up in the brain, and sometimes it can have profound effects on someone's experience of the world and how they act in the world. And so during that time, I certainly thought that psychedelics. If you're interested in drugs and behavior, either you have to be fascinated by psychedelics, or you really don't know much about psychedelics, given their history in our culture, but then even more broadly, their historical and then prehistorical use. The idea that the evidence that they've been used in sacramental fashions across many independent indigenous cultures is quite fascinating, and speaks to their something unique about them. And so I was able to actually get into that research during my postdoctoral time at Johns Hopkins, which is where I've stayed on ever since. So 16 years later, I've done quite a bit. I've continued working across all drug classes, and really the thing that defines me is my work is not really drug class. It's I'm kind of more interested in common principles. So, for example, in addiction, a lot of my work's in addiction. I'm not so concerned about whether it's addiction to this drug or that drug, or what the distinctions between them are. I'm more interested in the things that are common amongst addiction, which explains my early interest in delayed discounting and um, using behavioral economic demand to understand drug consumption and principles like that. So, yeah, I kind of dabble. I dabble with all the drugs in the research lab and the behavior that follows their administration.
Awesome. What it must have been kind of, so what was it like kind of encountering this research as an undergraduate where you're like, holy crap, what are you guys doing? You're giving cocaine to rats? Or were you aware of this research? I'm just kind of curious what that original exposure to this line of work was like.
Well, it actually wasn't going on when I was my undergraduate advisor had published a paper before my time there on some early work, and so it wasn't like they had an active research lab.
Okay.
They had an active rat lab that was mainly there for teaching, for class assignments. So training students in the upper division classes to shape up rats, to
I
press
see.
levers and do simple experiments. And which is, I don't know how much of that still goes on at the undergraduate level, but it's I think it's really invaluable. But yeah, so during the time I was there, we decided to kind of get the research. I mean, it was a small undergraduate school, so if you published a paper once every 5 years, you were well ahead of the curve in terms of publication. It
I see.
wasn't the strong expectation. So we got things up and going again with cocaine and rats. And so yeah, it was kind of this was all new to me, but it was fascinating, the idea that like you had the special permission. And of course it was my undergrad advisor, that was handling this and storing the cocaine. But like, yeah, if you had the right little license, you just kind of order it from the chemical company, from Sigma Aldrich or what have you, and you kind of get it and you lock it up in your cabinet, and mix it up and inject it into the bellies of rats. And yeah but that sort of then my research, I mean, since has gone so many different levels. Like most people are kind of when they learned that, you can actually give people cocaine and methamphetamine and these various drugs in the lab. They're, more shocked by that than the rats. But I remember just the fact that you did this stuff with rats,
Yeah.
was just was a shift for me. And
Yeah, I think there's something interesting about just having access to those things as well, for and that it's not illegal. Like, one of the things I
yeah,
was involved with, some, as a graduate student, we did research on the olfactory capabilities of dogs, to detect a variety of things. Both, and we had like all sorts of drugs. We also had things like plastic explosives and TNT and all sorts of crazy stuff. This is all pre 9/11. I'm sure it's a lot different
right,
right
right.
now in terms of the oversight of those materials. But it's like, oh yeah, we had to, we're going to the bunker to get some TNT. We'll be back. It was just all very casual, and it's just kind of,
No biggie.
yeah, yeah. So, but I remember
Wow.
being completely shocked at the outset, and then you have these kind of conversations with people you meet, like randomly, and they're like, "What? You do what with what?" Are you in need of continuing education? Well, Behavior University is a BACB approved continuing ed provider, and their mission is to provide university quality courses and ABA for new and experienced professionals alike. Their live webinars generally have a limited number of attendees so that the learning experience is highly interactive. And if you can't make the live events, these webinars are recorded and available in Behavior University's CEU library for later viewing. Behavior University also has a 40-hour RBT training. This self-paced course uses a combination of visual presentation, audio lectures, and live video models to teach all areas of the RBT task list. The course is accessible anytime and from anywhere. So if you'd like to learn more, head on over to behavioruniversity.com/observations, where you'll find a 10% discount for podcast listeners. Again, that's behavioruniversity.com/observations, and thanks for checking them out. To kind of maybe get a little bit out of my foray down the memory lane with your work here, or at least move the timetable forward a little bit. We were chatting again in our email correspondence leading up to this interview about some of the stuff that you've done, and I know you were spending a little bit of time talking about psychedelics, but you also have done a lot of work with cannabis, and of course, and at least in this day and age, the cannabis is a, very, it's hard not to get exposed to it, I suppose. Gosh, I'm trying to choose my words carefully, but I guess it's not any, just with all the different ways in which states are kind of
Yeah.
relaxing, their laws and what, in the ways in which people are getting access to it, whether it's medical or recreational or whatever.
Right.
But you've done some work in the use of cannabis and its effect on delayed discounting. Can you talk a little bit about that? And I know our listeners have, we've had a number of behavioral economists on the show. So longtime listeners will, recall some of the basics of this. But for those who are new to it, if you can describe, the delayed discounting procedure and how that related to your examination of the effect that cannabis had on it, that would be great.
Yeah, sounds great. And with your discussion of the exposure to cannabis and the careful selection of words, like that's good because it could have sounded like the old story of like, oh, it wasn't me, it was I was standing next to a guy
Hmm.
at a concert, and like back in the days when you went to concerts during the COVID
Sure.
shutdown here, but I've done research testing people for their urine for substances for so many years now that you've heard all of these excuses and
Yeah,
anyway had a little different meaning there,
that's
but
right.
yeah,
That's right. Yeah,
yeah,
it's kind of like an
cannabis is
extension of
everywhere
I'm
and
holding it for a friend.
right um so yeah, I think cannabis is really it's fascinating to think about with delayed discounting, which for those who might not know is it refers to the devaluation of future consequences. Typically we talk about rewards as a it, does one value a reward less because it is delayed into the future, and sort of it's relates to the idea that we all else being equal, you'd rather have a good thing now than later. um And I was fortunate enough in my early graduate work um, to work with, and throughout my graduate career, to work with Warren Bickel, who was one of the primary individuals, perhaps the primary individual, to really solidify the um, the idea that delay discounting has a whole lot to do with drug addiction and other forms of addiction. So really, I mean, I we made the we made the proposal that it really constituted a fundamental behavioral process um, uh, that underlied addiction, and and so some of the work, and just did work with tobacco and cocaine, and also in the lab there had been work on opioids, um, largely comparing people who met um, uh, DSM dependence criteria to those who nowadays you'd call it substance use disorder with the newer DSM, but to those who were demographically matched. And the typical pattern was that people would have higher delay discounting for money outcomes when they were dependent on a given drug, compared to match control people of the same age, gender, educational background, etc., who weren't dependent on that drug. And uh and we extended that to cannabis, and so that was interesting. We published a null result, which I'm always proud of the null results that I publish. I think we don't publish enough null results. The file drawer effect is not a good thing in science. And however, the we found a trend that was in the expected direction. I should say the typical direction is, buy higher, greater delay discounting. I mean that, given choices between smaller, sooner amounts of money and larger, later amounts of money, on average, the finding is that the drug addicted person is more likely to settle for a smaller, sooner amount of money, um, rather than the larger, later. And so, relatively speaking, the control non-addicted individuals would be more likely to wait for larger, later monetary rewards. And it's more complicated than that, because you're talking about at multiple time points and the analysis of a curve. But that's the brief of it, and that tells you the most important thing. And so the results weren't statistically significant for cannabis, but they were in the expected direction of cannabis dependent folks, heavy users, uh, delay discounting more, more likely to choose smaller, sooner monetary rewards over larger, later rewards. And and in the paper, our strongest speculation was that eh, there probably is an effect here, but it's likely smaller than with other drugs. And interestingly, that's what we found in this recent meta-analysis that Justin Strickland, a postdoc in my lab at this time, he was the mastermind of and put together, um, and essentially landed. And now that, so we did the first, back in Warren's lab, the first study on delay discounting and cannabis, and now there have been, well, there were 27 studies that we found and included in our meta-analysis. So fast forward some, what has it been, uh, 12, 13, 14 years. Um, and on average, the result looks about right at about the same effect size as that we originally found. Of course, with, I think we had about 25,000 participants across the various studies, statistically significant,
Wow.
with all those pooled, data, but it's a small effect. And it's interesting, you can speculate about why that's the case. My best speculation is that, there's a lot of reasons to use or to not use any given drug. And you talk about drugs like tobacco and cocaine and alcohol, a whole lot of the reasons not to use it relate to very strong negative health outcomes that are delayed. I mean, the biggie is like tobacco,
Sure.
where, there's almost nothing. I mean, even like, if you're have an alcohol problem, you get in a drunk driving accident today, or you could, sometimes people drink so much they actually just stop breathing, acutely overdose, lethally overdose. Not very likely to happen with tobacco. You're almost guaranteed not to have a problem in the short term like that. But it's one of the worst out there. In fact, it's by far, in terms of the number of deaths, it's far greater than any drug, 4 times alcohol, and it completely dwarfs all illicit drugs in terms of number of deaths.
Wow, I
So,
didn't know it was that
uh,
much more than alcohol. Holy cow.
right, yeah, you're talking about almost 500,000, so 500,000 people a year, and something a little over for tobacco, and then something like a little over 100,000 for alcohol in the United States. So yeah, about 4 times the number of people die from tobacco than alcohol, and then the other drugs, cocaine and everything piled up. Even the opioid crisis piled up, barely shows up visually if you plot them on the same chart. Not to dismiss the importance of the opioid crisis, but we can't forget the biggies, and the biggie of the biggies is tobacco in terms of the big killer. And but relatively speaking, out of the good and the bad that happens with any of these drugs, so much of the bad for tobacco are these delayed, horrible consequences. The various cancers and the cardiovascular disease. And cannabis is very different in that sense. Now, certainly, there's reasons. Uh, Anything, you're going to have upsides and downsides. There's plenty of reasons you can list for not using, cannabis. Certainly, acutely, short-term memory is not enhanced. It's made worse with cannabis. There are even not acutely, until at least about one has washed out for 30 days. There are small but reliable and detectable decrements in various cognitive tasks, um, uh, like verbal memory. But these things are not. It's not the cancer that's gonna. It's not the lung cancer that's gonna
Sure.
kill
It's
you
not emphysema.
15 years from now, right? Um, and certainly, it's not to say none of that. It's certainly not the sledgehammer that tobacco and alcohol are. Not to say there aren't any long-term health outcomes, but it's not even on the same. It's nowhere. It's not even the same ballpark as drugs like tobacco and alcohol. So and really thinking about what mediates behavioral choices, it's probably even a more extreme effect in terms of people's perceptions. There are plenty of people that say not only like cannabis has absolutely zero downsides, but it has nothing but upsides. And certainly for those people, if one doesn't recognize any long-term aversive consequences, then in terms of sort of in terms of selection, in terms of who chooses to use this drug or not, it's going to kind of even you know uh, exacerbate probably an underlying reality that at least cannabis is realistically associated with at least far less long-term health consequences. Not that there aren't any, but far less long-term health consequences than tobacco. You have someone actually believing there's nothing but positive long-term health benefits. um, you're probably not going to see an association with delayed discounting, or at least you're not going to see as large of an association. So that's my best guess about what's going on there. And that as we had proposed in the original study, if you had enough subjects, you could probably show this effect. And now across studies, we certainly see that effect is statistically significant.
Got it. Wow. I'm tempted to go in so many different directions with this, but I also want to kind of sample some of the things that you've done work with as well. So as much as I'd like to continue down that particular line of research, I know you've done quite a bit of research looking at choice making and condom usage. So we just need the rock and roll, and then we can complete the trifecta here of sex and with along with sex and drugs. But so can you tell me a little bit about some of the research you've done with regard to that topic, and what were you looking at? What were the independent and dependent variables? What questions were you trying to answer?
Yeah. So with condom use, you know, the basic task, we've developed a few tasks at this point, but the original task, the sexual delay discounting task, we pitted condom use decisions in a delay discounting framework. And so it's simply, we set up and this is, these are hypothetical decisions, like much of the delay discounting research, but hypothetical decisions where one selects the photo of a partner amongst a set that they find attracted, they'd be willing to have casual sex with, and and we set up a vignette and say this person wants to have sex with you. Um, First question being, there's a condom there. Rate your likelihood of using the condom. And then the next question is, okay, now imagine there's not a condom available right now, and we want you to rate your likelihood of engaging in either one of these two behaviors, either having immediate sex without the condom or waiting. And this differs across trials, but waiting 5 minutes to have sex with the condom. And then, like a typical delay discounting task, that delay varies. So we've done some different variations of this, but you can, I think we've gone out to 3 months. You can,
Three
but
months.
right, and that's why our more recent versions have kind of scaled back from 5 minutes to 24 hours being the range. Whereas, like, okay, what is 3 months miling? Probably happens, like, I don't know, kids at a summer camp and they won't see each other for, like,
Right.
you could stretch for an example of, like, we're not going to see each other for 3 months, but
Someone going abroad for a semester or something like that.
right, it's now, or you got to wait till September or something. But in it, kind of speaking to the robustness, it doesn't really matter, it seems, what time frame. And this is sort of like the monetary work. You could critique research has gone up to 50 years. The more typical thing is 25 years, but about how realistic some of these delays are. But you see the same hyperbolic like shape unfold. It seems no matter what time range you use. And so we find that this likelihood of ratings for condom use drops off in a hyperbolic fashion, just like humans discounting for money, just like pigeons and rats discounting for food and for water, and just like, oh gosh, I've counted it in the literature before. It's well over a dozen species of animals that have been tested with delayed discounting, and it, on average, it's this hyperbolic type form that prevails. So yeah, it looks and smells just like discounting, and the only thing that's being, the only thing that's shifting the choice across those different trials is the delay that changes. So it is a delay discounting choice. It gets a little, it's not purely the discounting of sex. In fact, some other, there have been various tasks that have assessed that. And that would be, people have tried different things. Like, would you rather have a few minutes of sex now or more minutes of sex later, or, one sex act now or several sex acts after some delay. And, there's always pluses and minuses for different research strategies that you might say those tasks, are, might be a little less realistic, modeling, have less ecological validity, but they are getting at the pure discounting of sex. The task I designed is one that really focuses more on a clinically relevant, how does delayed discounting really play out, in these types of risky decisions. And that's what I was interested in. And I also had in my mind that I eventually wanted to do drug effects on this type of task. And research had been published, the first one when I was in graduate school, claiming that, finding that alcohol didn't affect delayed discounting. And I always called BS on that. I believe the results they were reporting, but I thought, hold on, in the big picture, you're telling me getting drunk does not cause you to engage in behavior that that is a detriment in the long term. That where the short-term benefits are overriding long-term detriments that are going to come. And it's like, we see this all the time, without something like alcohol. It's like, I bet they just haven't done it the right way. And one aspect of not doing it the right way is, maybe we've looked at the wrong reinforcer. So amongst all the things that people do when they get drunk that are suboptimal, while some might, make poor financial decisions, like most people don't get drunk and start playing with their, retirement investments and whatnot, and some people do have gambling problems, but but more typical thing, I think, my impression is that people are dealing with primary reinforcers. They're eating that stuff that they even though they're on the diet, they've quit smoking a month ago, but now, well, what the heck, they're drunk, they're going to have that cigarette, and hey, here's a sexual decision where they'd normally be a little more risk averse, and now what the heck.
Yeah, I mean, there's even some stuff that, and it's not necessarily, I don't believe it's part of the discounting literature, but just the whole line of research on the anti-punishment effect, and the effect that alcohol and everything else that kind of acts on the GABA receptor, and so all the benzos and everything else that goes along with that, that's going to really reduce the effect that punishment has on suppression. And so, I know it might be a little bit of a leap to map that on in this case, but
no, that's always how I've thought of it. Exactly what you're saying. It's not a leap. I think that, alcohol and other GABAergic drugs are great at reducing the ability of a future punisher, which is a stronger effect than escape behavior, which is a current punisher. Like if it's a delayed punisher, it's just like alcohol's great at like abolishing its impact on behavior.
Yeah, we were taught that in grad school by Dr. Chris Newland, and it was the punchline of it is basically this is why people get in bar fights, which I always thought was a memorable hook to be able to store that factoid in long-term memories.
Right.
Are you looking for a new job, but you're overwhelmed with all the emails that you're getting from various ABA agencies? What if there was someone who was in your corner and could help you find the perfect job placement? Well, that person exists. Barbara Voss has been working as a recruiter for over 30 years, and her company, HRIC, specializes in placing BCBAs in permanent full-time positions throughout the United States. Barbara has been placing BCBAs since 2011, so she knows our business, and she offers personalized service to any BCBA looking for a new position. She also helps companies looking to hire BCBAs too. Here are just some of the things Barbara can help you with. She can provide information about salary ranges in different markets across the country. She can help you write your resume. She can coordinate and prepare you for the interview process, and even help negotiate the right salary for you. And best of all, there are no charges to any candidate for all of these services. When you're ready to make a change and want to work with someone who will listen to you and understand what you need in a new position, contact Barbara at HRIC. To schedule a confidential discussion, head over to hricolorado.com. Again, that's hricolorado.com, and hit the contact button to connect with Barbara. You won't be disappointed. So you're at Johns Hopkins, and what is it like conducting these studies? I'm just fascinated by the nuts and bolts of how these things are done, and even down to like the recruitment of participants, and where do you get referrals for these sorts of things? It's like, are there ads being put in the Baltimore Sun or on like the Baltimore Craigslist or something like that? I can imagine, come in and take some mushrooms or something. I don't know. Tell me how it works from just the real granular aspect of just how do you get people involved with this without freaking them out, or how do you get people do you screen for people who are like, hell yeah, I want to go in there, and I can imagine there's just a range of responses to just on the recruitment side alone.
Right. You're touching on all kinds of, like good intuition, because all of those we've touched on a number of concerns, and the short of it in terms of how we recruit, it's like basically, yeah, Big caveat: the Baltimore Sun is really pricey. So not just for us, but for the people that we want to be in our study. So there's the free local paper, and it's changed names over the years. It used to be called the City paper, but it's one of those. And there's in most mid-sized, large cities, there's one of these where the last half of of each issue is basically a bunch of ads for you name it. And it's where the type of paper you open up where you want the go-to for what music is playing this weekend and what's going on in town, that type of the free local,
Sure.
And so yeah, that's a great play. So if you live in a place like Baltimore, it doesn't seem odd at all to come across a bunch of pages, smokers wanted, cocaine users wanted, heroin users wanted. Like, it doesn't shock people around here at all, because I mean, Hopkins is the largest private employer. We also have other like University of Maryland, here at School of Medicine. So people advertising for human subject, and a number of CROs, clinical research organizations in the area. So advertising for human subjects isn't that strange, and advertising for drug users isn't that strange. So yeah, and that there's just so many issues that touches on. For all of the addictive drugs, which are most of the drugs of abuse we study, psychedelics, particularly classic psychedelics like psilocybin, is an exception. But any other recreational drug, if you think of, it has addiction potential. They all have abuse potential, but here I'm talking about addiction potential. It's a strong ethical concern not to expose someone to cocaine who doesn't regularly take cocaine.
Mm-hmm.
And it's also a strong concern to really make sure that you're not giving it to someone, even if they're using it regularly, if they're trying to quit. And that goes for smoking cigarettes, what have you. And you got to be nuanced about that, because if you ask them, it's like, if smokers, if you ask them, do you want to quit? Like, most people are going to say, yeah. Like 70% of US adult smokers will say, yeah. Do you have a plan to quit within the next month? That percentage dramatically
Let's get down
drops.
to brass tacks here.
Right. Which gets back to delayed discounting. But if someone has that immediate, desire to quit, then like, no, you don't want to keep, you don't want to pay them incentive to be them in a study where they actually have to do that drug. But the idea is, and a number of studies have published on this, like, do people exposed to cocaine and other drugs of abuse in non-treatment seeking studies, are they harmed? And something like well over a dozen studies have carefully examined this with hundreds and hundreds of volunteers across these studies, and the answer ranges from they range from neutral to actually benefit, even though these were non-therapeutic studies. The goal wasn't to quit the drug. And from having run a bunch of these studies, I know why. I mean, gosh, back when we used to have an inpatient unit, I mean, so often this was, even if they're getting a cocaine injection every few days under medical supervision, this is the first time they've ever talked to a medical professional about their drug use in their life. They're getting, they're talking about their substance use. They're getting medical and psychological attention. And so often people end up reducing their drug use and end up doing better. And plus they're getting some, a lot of these people have unstable housing, and they get a nice chunk of change from doing the study, so it can help their life out. But something like psilocybin, we've successfully made the case that's not the issue. Compulsive drug seeking, even though it can be used dangerously or abused, compulsive drug seeking or addiction is not something associated with classic psychedelics like psilocybin, which is in magic mushrooms, or LSD, the classic psychedelics. So we can give those to people who have never had a psychedelic before, without the fear that they're going to be a mushroom addict afterwards.
Yeah, that's my understanding, is that there's the addictive quality to those types of compounds is kind of nil, from what I understand. So, so I guess two different questions relative to this line of research. I guess one is, and David walked us through this too, but I think it would be a helpful reminder for folks, maybe if they didn't catch that episode, or it's been a couple of months since that episode aired. But I'm curious as to uh, two things. One is, what is the general process for, what does the intervention look like? When someone comes in, as we talked about, there's some screening aspect that happens, and then the person comes in and essentially, to use the colloquial term, trips, and so
Hmm.
forth. So I'd love you to go into detail about that, and then I'd also like to talk about, maybe we can talk about that first, and then secondarily to that. Um, I know a lot of this research has targeted a variety of behavioral challenges or behavioral health issues. So we can tackle those. So I want to talk about that as well. And so we can take those in whatever order you want. But those are two like really huge areas that I'm very curious about in this line of work.
Yeah, so there's a whole lot of thought and preparation involved, and just very strong risk mitigation strategies. So, first of all, people are screened. We know certain things, like if you have a history of or an identifiable predisposition towards psychotic disorders, then you shouldn't be getting high doses of psychedelics. That seems pretty clear. Um, and people with, for example, very high blood pressure that's not controlled, it's fine if they're on antihypertensive medications that have brought it under controlled levels. But someone that's any severe cardiovascular, anything that raises your blood pressure somewhat, could be a problem. So this falls into that category. And so screening, very rigorous screening, psychiatric and medical. Then there's preparation, ranging anywhere from 4 hours to 8 hours, depending on the study. Where the main thing is to get to know the two people that the participant is going to be with during the actual psychedelic sessions. So, one of the things that can lead to paranoia and panic reactions is being around people that one doesn't know. And so there's a strong rapport that's established. Really, everything that we know that goes into good um, psychological clinical work. We know studies have shown that the rapport, and in some areas, the rapport between the client and the provider is more important than the school of thought that the provider is trained in.
Mm-hmm.
I think good applied behavior analysis is an exception to that, given that it's so freaking powerful.
Sure.
But with so many methods, this is the case. And so you establish that rapport, and if it's something like if there's a therapeutic target, that content is included in the preparation as well, like to quit smoking. There's cognitive behavioral therapy to preparing them to quit smoking. So that's one of our therapeutic targets, one line of research for the psilocybin. Um, but for all of the studies with psilocybin, you not only develop that rapport, but you prepare them for the wide range of effects that psilocybin can have, which is basically a laundry list. You can be terrified. It could be the scariest experience of your life. It could feel like you're dying. And you don't have to weigh so heavily on the positive stuff, because no one complains if they, but you tell them, like, yeah, it could range from a beautiful, experience to a very challenging experience, and everything in between, and all emotions. You could be laughing your head off, and you could be crying like a baby. And under our particular model, you know, we say that that's, and it seems clinically the right thing to do. Uh, the best strategy is to welcome all of that, go with the flow. Don't, if you feel like laughing, laugh. You feel like crying, cry, like you're in a safe container and you're not being judged. Um, and when it comes time for the actual sessions, this is a clinical model that goes back to the 1950s, before anyone on the street knew what the term psychedelic meant. The term developed around psychedelic therapy, and what that meant was a high dose of one of these compounds combined with preparation, as I've described, but also wearing eye shades, and then listening to music. So, which generally encourages an introspective framework. So, not interacting with the environment or minimizing that, and and essentially preparing the real work goes in beforehand. And so the guide or the therapist is not doing a whole lot of talking during the experience. They are there at that point as a safety net should anxiety or panic creep up. And one of the most powerful things is just to hold their hand. If that to verbally reassure them, remind them that they're safe, what's happening, and that you're not leaving them. And you also have two guides, so that even if one's in the bathroom briefly, there's always another human being that they've developed some trust with, who can reassure them. And then when the person starts to come down, you basically talk about the experience. You allow them to talk about the experience, and if it's something like quitting smoking, sort of like the next day, and other sessions really more focus on the therapeutic target. But there's not a whole lot of programmed, or there's not any sort of program. We're not encouraging to think about quitting smoking during the psychedelic experience.
Hey everyone, as a BCBA, meeting your continuing ed needs can be challenging at times. That's why I have made selected episodes of the Behavioral Observations podcast available for Type 2 continuing education credits. That's right. You can meet a portion of your professional development requirements on the go. Currently, we have CEs for topics including functional assessment, ethics, and supervision. Come learn from podcast favorites such as Greg Hanley, Pat Fryman, Mark Dixon, as well as many other amazing guests. For more information, head on over to behavioralobservations.com/get-CEs. That role of the guide is fascinating, and it kind of reminds me of, at least this is just the experience that my wife and I had, but when our kids were born, they were born at a hospital here in New Hampshire, Concord Hospital, and they had just awesome nurses, and we were assigned a nurse, and that nurse basically was, as long as the shifts aligned up, that nurse was our guide, essentially, in the same way in which you've described. As you rapidly develop rapport with this individual, and they are, and they kind of shepherd you through that process. And of course, I'm, describing this as the observer, not the direct participant. But I know my wife felt the same way. So yeah, it's just interesting to kind of think about how potentially important that person, the role that person plays in that experience.
Well, I think you're spot on, because I'm thinking of one of our participants in our cancer study. So we had a study with 51 people using this to help people with substantial depression or anxiety because of their cancer diagnosis. And one of the participants was a midwife, professionally, and she said, "This is what I do." Like, your whole gig, this whole thing about how you do these psilocybin sessions is exactly what a midwife does, and exactly what you were describing with a nurse playing similar role. It's like, and I mean, that's been in my experience in my personal life, particularly. Nothing against physicians, but compared to physicians, like, so often, like, it's the nurse that takes the time with you. And I mean, I've had clinical situations with family members and whatnot where it's like, because the nurse actually took the time to speak and to actually get to know you deep down, that they actually notice something clinically that ends up making all of the difference. Whereas that just wouldn't have happened in that 5 minutes with the physician. So it really is. It's that's a really great point you were making there. It really resonates with me.
Yeah. Thanks. So we have, is this done during like the daytime?
Yeah, it's a 9 to 5 thing.
Okay.
Which is one of the reasons, not the only, but one of the reasons we work with psilocybin, not with LSD, even though I've recently, it looks like I'm going to get some funding to do a small trial with LSD, but those are going to be some long days. But psilocybin is sort of a 9 to 5 thing. They can be sent home with their loved one at around 5:00 if they come in at 8:30 in the morning or so. Effects are completely resolved by the end of about 6 hours of active effects.
I see. Okay. Yeah. I can imagine with LSD. Yeah, that would be a very, very lengthy course of treatment, I suppose, if they were taking LSD. Now, you start talking about high dose. How do you? compared to what, I guess, is the question. Like, what does that mean? I've often, in kind of like the Joe Rogan, type descriptions of these or Tim Ferriss descriptions of these sort of things. I think the term heroic dose is thrown around,
Right.
as a descriptor. Um, have you done studies on the dose response relationship, yeah, or this is just kind of, how do you determine the dose, I guess, is where I'm
Right. So
rambling
exactly,
towards.
that's the first study that I got involved with directly, um, in designing and running was exactly, it was a dose effect study with a true placebo plus 5, 10, 20, and 30 milligrams body weight adjusted. So those doses per 70 kilograms, mgs per 70 kigs. And yeah, so that's the kind of the most credible work that's been done examining a full dose effect curve. And it's an interesting dose effect curve because um you get increases in kind of the positive effects. And so we found in a number of different ways that the so-called mystical experience, I'm not sure if we want to get into that, but it's this kind of psychological construct going back to William James, but this mystical type content, that the more of that, the better these long-term in the session, the better the long-term outcomes, whether it's reduced distress due to cancer or more likely having been biologically confirmed abstinent from smoking, or in terms of increased personality openness. It seems that the nature of the experience, has some, relationship, to the outcome.
So are you saying, so unless you really get a good hit of it, the returns will be minimal, if anything?
That seems to be the case, which is why you use the high dose. But so from going to 20 to 30, you increase the probability by a few percent of having that. It's an arbitrary threshold, but the way we've defined a full mystical experience. But from going to 20 to 30 milligrams, you're also increasing the chances of a challenging experience. In other words, a bad trip, by about sixfold. So it's a really interesting. So the really interesting dose range to play with is 20 to 30. The other big caveat to there is that the in this clinical context, a bad trip isn't necessarily bad, which is why we call it a challenging experience. So many people say that having one of the, even though we try to minimize them for sure, it seems unavoidable. Like there's a chance you're gonna, like, you might even think you're dying. But so many people say that in retrospect, that was a very valuable experience to have gone through, even though we try to minimize it. So, but like you're working on a certain disorder that might, people might have more trauma history, whatnot. You might want to play on the lower side of that range, and be a little more cautious. But that's the range, the dose effects. And in terms of the heroic dose, yeah, this is the class 30 milligrams, the high dose, which is in most of our studies. That's kind of our standard dose, based on average doses of Psilocybin cubensis mushrooms, which is the most common type in the US. It's equivalent to right about 5 dried grams, which is the classic Terrence McKenna and what it's what Joe Rogan draws from, the classic heroic dose, 5 dried grams of cubensis mushrooms. It is. We've had plenty of volunteers. We've done a number of studies where we want the psychonaut, the people with tons of psychedelic experience. So many of those folks have said afterwards, "Holy cow, you guys were not screwing around. That was the strongest psychedelic experience of their life."
Wow.
This is not something that most people want to ever take at a concert. It's something that the real psychonauts say, like, yeah, this is when you get into bed and you hopefully, people have different opinions out there in the world, but like, you want to have someone there in case the house catches fire, if nothing else, and you're not interacting with the environment. Like that shouldn't be on your shoulders at this time. And there are doses that can lead to, I mean, you name it's been interesting for me with the behavior analytic background, which is why I've pushed towards understanding behavior change with stuff like addiction and biologically confirmed behavior change. But these subjective experiences, call it ego loss, like people will say the most extraordinary things about the nature of these experiences. And again, can feel like they're dying, can feel that they are one with the universe. They can, to put it mildly, often people don't feel like themselves. And,
Right.
yeah.
Um, so I want to get back to the whole bad trip thing. The so someone could let me make sure I'm on the same page as you. So someone could have a bad trip yet still yield a positive clinical outcome. Let's say they go in there for smoking cessation. So is that what you were saying about how being a
Right.
bad trip isn't necessarily a bad? I mean, obviously you try to avoid it, but it's not. It doesn't necessarily alter the potential efficacy of the intervention. Is that fair to say?
That's absolutely fair to say.
Okay.
And sometimes people will feel strongly that that was it, that going through the hero's journey, including the nadir of it, that they, that was it. Whatever analogy you want to have, like, this is like, going through their own death, looking the demon in the eyes, looking into the basement of their own, within themselves, and seeing all of the horrible things that, like, we don't like to admit, and that all of this could be part of the bad, so-called bad trip, and the existential terror, of, yeah, of the self, not existing. Like, this can hit home for people. And so the idea of having gone through that, many people will claim, was incredibly beneficial, even if sometimes they wouldn't wish it on their worst enemy.
I understand.
Yeah. And I think of, that's analogous to stuff we need to know more about. But, think of traumatic experiences. Like, most people don't get PTSD. People play with this concept of post traumatic growth. The idea that if the environment is right, and we don't know enough about what pushes people in one direction or another in real life, but in one of these, experiences where everything is controlled. And actually, I should say, we have survey data suggesting bad trips, if you come in with psychopathology and under the worst of circumstances, where there's not even a buddy with you, like, that's where things can be worsened. Even something like depression can be worsened, rather than, as our data is suggesting, getting better, improved in these types of controlled situations. So, it's like life experience itself. It's like the bad stuff in life is sometimes, in retrospect, the thing that made you grow and that you learned most from.
Is that kind of like the hypothesis? I guess one of the things I'm curious about, and is is that kind of like the mechanism of action, or at least, and the mechanism, what is the behavior change agent here, and is it this exposure to maybe taking yourself less seriously, or and then we're getting way far away from kind of objective, measurable, definable stuff here, but
Right.
um
Yeah.
is
And
that
we don't know yet. And we're trying to figure it out. We need larger numbers. We're collecting these, as best we can, subjective data on these experiences. You know, there are I could. It certainly seems clear that it's not necessary to have one of these. Like, 2/3 of our participants don't have a challenging experience, and they also, on average, have lots of benefit. And so,
so
not
someone can
everyone benefits, to be clear, like with anything. But
So someone can go in there and just kind of like, kind of laugh their ass off and, you know, um, but not have some sort of, metaphysical experience or something like that, and yet still derive the outcome of that they were looking for, that this research team was examining.
it's possible, but it tends to be that people with more meaningful experience, that, and this is all self-defined, if the person judges it in retrospect to be meaningful, that is predictive of long-term benefit. But it's like, it seems the valence of that could be difficult, or, beautiful. So it's now, with someone just laughing their ass off, it seems the data suggests, if that's all they had, it seems less likely that they would benefit from that. But in terms of, whether it's a very frightening experience, or one that, one has this sort of transcendental experience where they feel like they have an empathetic experience with all of humanity, for example. Whether it be that or the experience of being frightened out of your wits of dying, it seems like those types of intense experiences are the things that carry the therapeutic impact more so than just like, in the example, laughing your ass off. So we're figuring it out. But it seems to have, the best we can say is it seems to have something to do with the so-called mystical experience. I think the core component of which is this subjective sense of unity, which can be experienced either as a very positive thing or a very negative thing, but kind of going beyond oneself subjectively in the experience.
Got it. Now, I know one of the things I think that just kind of makes me, just kind of gets my kind of skeptical brain going here a little bit is that, we've seen studies, and I know you guys have been involved in a lot of looking at using psilocybin to examine a variety of different behavioral health challenges, and it seems like is this something that's good for what ails you, if you will, and should we be skeptical of that? It's like, um,
Yeah.
it's like, well, I've got a hangnail. Well, psilocybin, I'm not sure, like, I'm kind of being a little facetious, but if you think of things like
Right.
depression and smoking cessation and so on and so forth. Can you talk to I guess the generality of this? And is that something that you're concerned with or perplexed by, or yeah, yeah, if you can just kind of
All
speak
of
to
the
that.
above.
Okay.
Right. And really, I think you've come to, I think, the biggest issue for me in this area. I mean, like, it's weird enough to have a substance that, in the early research here, and if things hold up, it looks like it's good for not just one form of addiction, but not just tobacco, but alcohol. Um, my colleague Peter Hendricks at University of Alabama, Birmingham, is finding positive preliminary findings, even treating cocaine addiction. If these results hold up, that's weird enough. Okay. Like, most addiction medication is not cross substance, then to say, okay, it seems to be working for depression and anxiety in cancer patients and just garden variety major depressive disorder. Um, and now we're exploring, we don't have data yet, but we're exploring treatment of anorexia, and I'm starting trials with, haven't started them yet, but have the funding for it. So we'll be starting them on PTSD and opioid addiction. And there's some older research on LSD, suggesting, preliminary, but suggesting it could be effective. So either we're selling snake oil, you should be skeptical. Like, either this is snake oil and there's a story being spun here, or we're on to something really, we're on to something. And I think if these kind of results hold up, it suggests that we are getting at mechanisms that are common across these nominally distinct disorders. So my best hope is that this could be useful in the RDoC framework. So this system that has been implemented by the National Institute on Mental Health, with the idea that the DSM, psychiatry, clinical psychology, compared to other areas of medicine, our disorders are completely descriptive. They're not based on a mechanistic understanding the way heart disease and cancer is, and
Hmm.
any other medical disorder. And so the idea is, like, what are the underlying biological and behavioral processes that are driving these disorders? And it may be more in common across disorders that we lump into different categories. So we've got to follow the data. But something I'm intrigued by are, what are the commonalities between affective disorders and addictive disorders? I view them, broadly speaking, as both ways as narrowed behavioral repertoires. And narrowed in behavioral, I'm thinking, as in the spirit of radical behaviorism, thought is just a form of behavior. You got to be mindful about what you can observe or not. But if it's happening, it's seems completely parsimonious. It's following the same laws as any other form of behavior. So the idea that people are stuck in mental ruts, thinking about yourself in a certain way, the self-persecutory thoughts and depression that we all have, but that are overexpressed in depression, and that those thoughts, when they get to a certain level, it makes it hard to actually get away from using those thoughts, in the same way that using a substance at such a level makes it hard to get out of that hole of, and be able to not use that substance. So these are behavioral ruts, of different forms.
I see.
Maybe psychedelics are a way, and we've got so much to figure out here, of radically shaking up the nervous system, inducing a form of behavioral plasticity. And I think we have a whole lot to figure out in terms of what's been called the afterglow, the period after the psychedelic session, where there's some signs in rodents that there's some neuroplasticity increasing during that time. It may be this period of increased behavior change potential, that could be brought to bear on these different forms of being stuck, be it depression or addiction. And the other thing to say about this generally is that I have no doubt we're going to hit boundary conditions. It may not work in anorexia. It may not work, with depression associated with Alzheimer's, another thing we're starting to study. So I think, like anything, yeah, we have to be empiricists and just keep following the data. I bet we're going to hit boundary conditions, and we have to be open to finding out what those are.
I think the thing, I was planning to ask you what it's like to be like the media's go-to guy, given that you've gotten all these mentions and interviews and things like that across these very storied, institutions and media outlets. And, but I think the humility in which you're saying, we don't know, we have work to do and things like that is kind of answering my question. I was going to ask you, is that stressful, but just the way you're answering that question kind of, in terms of validating the skepticism that we should have about these sorts of things and acknowledging all the things that we don't know, I think kind of maybe answer that question before I had a chance to ask it. So
Yeah, that's a great point. That's how I feel, that like there's this difficult balance to like, hey, I really do think this is an area that there was some good early research. I mean, even just the modern clinical trials weren't like really a thing when these things were first discovered and researched in the 50s. There was this promising early era of research, and then they were put on a deep freeze for a few decades for completely political reasons. And to be clear, there definitely, there were some risks of when people were using LSD widely on the streets, psychiatrically vulnerable people. But in terms of the research, we got to a point where it's like you couldn't do human research with rigorous controls for decades. And, that frankly was ridiculous. And I think the culture was sort of traumatized with the role that psychedelics played, and so many of those changes that happened in the 60s, and we had to kind of wait for enough time. And so now we're back there. So I want to play the role of saying, pay attention to this. This could be a big thing in mental health, like not just as potential treatments, but as a really powerful tool to understanding the connection between brain and behavior. That on the one hand, versus like, yeah, watch out for snake oil, because like there are charlatans around this stuff, and there are abuses that are waiting to happen and that do happen. I mean, you don't have to look far into the ayahuasca use and, to find sexual abuses, people kind of going the guru route. And I mean, everything that you see that is a potential in, like, say, religions, when you ordain someone in this special role, and even if most of the people hold that responsibly, that gives you special access with more power to corrupt yourself and abuse people compared to your average person on the street. And so it's hard to be associated with like what might be one of the most meaningful events in someone's life, by their description. And like, we've got to be really mindful of that. And we've got to be mindful of the high, like not overstating it, like just constantly saying, okay, the results could change if the results hold up. We're going to hit boundary conditions. We've got to follow the data. But you pick your audience, and they can go off the rails on one side or the other, in terms of, oh, this sounds ridiculous. How could this ever be medicine? How could we ever really treat this seriously as a tool in neuroscience and in terms of behavioral science? And on the other hand, like, oh, you see the worst of like the cannabis industry, where it's like, CBT work cures everything, absolutely everything, like, it's difficult. It's going to take wisdom and following the data to find the right path in the middle.
Bring CBD up. Yeah, it's an example of that.
Yeah.
Right. It's good for what ails you. Do you know if anyone's done any work in the chronic pain area with psilocybin?
There was a recent paper, a theoretical paper, making the case that it could be useful for chronic pain. There was some that psychedelics could be used for chronic pain. There was early research in the 60s, actually preceding the work with cancer patients for depression that went on with LSD in the 60s. There was some work just using it as a novel analgesic, and actually found astonishingly analgesic effects in these cancer patients that lasted longer than the drug effect. So in the days and weeks following, they had reduced pain. It wasn't randomized. It wasn't, it was just purely descriptive. But I think I mentioned with some recent funding that we'll be receiving to run some LSD research. That's actually going to be for the treatment of chronic pain. And so we're going to be testing. It's a very small pilot study. Hopefully, if we get some descriptive results under well-controlled conditions, it could lead to increased funding to keep looking into it. But, looking at LSD to see if it could help people who are using opioids for chronic pain, medically prescribed for chronic lower back pain. And the evidence basically suggests that, opioids are great for acute pain, but just for chronic pain, like, there's really no net benefit. And there's this obviously huge risk this is a major funnel into the opioid epidemic. People going off the charts with this stuff. And so anyway, yeah, we're going to be looking at that. It's an area of intense interest.
So when your name kind of came across my radar screen, I was just minding my own business, listening to the Tim Ferriss show, and he had done a panel, I think, at Johns Hopkins, if I'm not mistaken, and you were one of the participants. And I think it was around the creation of the center. Do you want to talk a little bit about that and the type of the general, I guess, mission of the center?
Right. Yeah. So our group has been doing, I've been part of it for 16 years, like nearly from the beginning, since 2004. But so we've always been a group studying psychedelics that has expanded quite a bit over the years. And but now we've sort of center has this kind of special meaning at universities. Basically means a certain level of money. You get enough money, the university will allow you to call yourself a center. And so so we got about a $17 million philanthropic donation from a variety of folks, including Tim Ferriss. About half of it came from the Stephen and Alexandra Cohen Foundation, and the other half came from Tim Ferriss and several other individuals that he rounded up, essentially, that he was the leader of, and encouraged them to invest. And he said it's the largest philanthropic donation he has personally ever made in his life. And so it's basically providing a lot of strong infrastructure. We've always done this stuff on a wing and a prayer, with I don't know, like 2% effort on a project where you're really spending more than that. And it's like, you're basically not drawing any of your salary from it. And, you get these small that we're ever grateful for, but we've it's been horribly underfunded, and we've tried to get as much work as we can. But now we have like some substantial funding where we can put a lot, have the amount of staff that we really need, have some capital investment in terms of we're getting multiple additional session rooms built for conducting these studies, and 8 new studies. So I've mentioned a few of them: the opioid addiction study, the PTSD study. We also have a study looking at comorbid depression and alcoholism. Study looking at depression within Alzheimer's patients, anorexia, several others. It's so both the support, a lot of like types of support, but also then some new disorders to study. And kind of a biggie is like, as the, our academic colleagues will appreciate, it's like salary support. And
Right.
we're at a, as a non-clinician in a place like Johns Hopkins, we're on soft money, so like you eat what you kill, so like you got to bring in the grants to keep your job. So it's like having 5 years of support for our growing number of faculty. That's kind of one of the biggest deals from it. Allow us to focus more fully on psychedelic research.
Do you think that, or do you have a prediction or a sense of, and I won't hold you to it, of course, but when these types of treatments might be more broadly available? And then secondarily to that, do you see a point in time where people who don't have acute behavioral health needs would benefit from these types of interventions just to enhance general well-being or what have you, or maybe subclinical behavioral
Mhm.
health challenges, or I don't know if that's the right term or not, but I think you get where I'm going, right?
Right. So I think in terms of these things being approved, probably something around the next 3 years, you're going to have the first indication. Probably the first is going to be MDMA for PTSD. And that's work that we haven't done at Hopkins, but some good colleagues have done that. Probably just after that is going to be psilocybin for the treatment of depression. And then I think probably not long after that is psilocybin for the treatment of smoking cessation, alcoholism, all based on the, the big caveat that like, the phase 3 trials like continue to show safety and efficacy. But yeah, that's my prediction. 3 to 5 years, we're going to see these initial indications. And then probably the real work is going to start. I mean, then it's probably going to be for limited people at the beginning, very tight inclusion criteria. And then I'm personally proposing very rigid REMS system, the risk evaluation and mitigation strategies that FDA can impose when they approve a drug. So keeping it very tightly controlled. Getting to be done own still there's yet to be any NIH funding for therapeutic research with psychedelics, unless you count ketamine, if you count that as a psychedelic. So I think then the real fun is going to start. I think this is going to field is going to expand, and then hopefully we can keep testing new disorders, novel compounds. I looked into it actually earlier today and did the math. It looks like there's around $400 million that's been invested into over 25 companies over the last couple of years, startups that looking that really think there's a future in developing these compounds. So I mean, there's the potential for novel compounds. I mean, we know there's actually hundreds of compounds. I mean, the field has worked on like 2 or 3 of them and over the last like 20 years, but there are hundreds of known psychedelic variants, all with slightly different receptor profiles of effects. And there's compounds yet to be made. So yeah, I think we're just scratching the surface with this stuff.
I see. Um, What, if any, and if you're not comfortable speaking to this, we can certainly move on to the next question. But how has this work of yours, this kind of career of yours, informed your view of public policy? And is that a question you get asked by policymakers? Given that your I guess visibility in popular media circles.
Yeah, it's I I just ever want science policy to be more informed by science. And at the same time, there's also within science, we have to be very aware of our contingencies where I do frankly think in a lot of the psychedelic area, people are understandably risk averse. The scientists are, and I find myself, at least within probably the last decade or so, more willing to be vocal about sorry about that, the about policy. So a number of initiatives have popped up to decriminalize psychedelics at the local level, which there is concern that if this stuff could derail this very kind of like that's going to go the way of cannabis, where there's this competition between local and federal initiatives, and everything we and others have done so far is like right by the book. It's the FDA pathway. There's absolutely no kind of conflict between local and federal law. It's not by ballot initiative, any of that. Um, but these initiatives have brought up like this like really complex issues. I mean, I feel strongly based on the data, and I think most serious scientists that study drugs that are willing to speak to it are in agreement. Like strong drug criminalization has had empirically demonstrable um, negative effects. I mean, think about it behavior analytically. The things that we know are, important for decreasing drug use and addiction, the harms, education, opportunity, access to alternative reinforcers. It's like, what do? You cut off all other reinforcers, you put someone in jail and you make sure they don't get an education, and you take, you know, it, and so it's not just theoretical, like I just described. Like we have data on this. The kids that go to that are incarcerated for that demographically look the same as other kids that aren't for a drug crime, they do worse, and this is kind of like the research we know on, like, this is why group probably why group like child like dealing with children with behavioral problems, like group therapy is not good. The research shows that, like, you don't put all the bad kids together so they can make connections, basically. um so and just like giving people criminal records and make sure they can never have like decent employment because of something they did when they were 20. I mean, I'm here in Baltimore where there's generations of poverty and only 30% of people like graduate from high school, and so many especially black men have are barred from opportunities or have been locked up because they when they were like 20 years ago, when they were at the height of being a young knucklehead, 18 years old, they were selling some cocaine, small amounts of. I mean, this is it's the whole idea of strong criminal prohibitions as the way to address the really strong harms of drugs is just it's empirically, theoretically, from a human rights perspective, haven't even mentioned the racial disparities in the enforcement. It's a bad idea, and thankfully, in the last several years, there's bipartisan agreement. Trump brags about criminal justice reform, and that, like, so I feel comfortable saying drug decriminalization is a good thing. That is not the same thing as encouraging people to use. It drives me crazy that some of these initiatives say, look at the research at Hopkins and elsewhere showing potential medical benefits, therefore legalize mushrooms. Well, like, no, that's not the way it should work. But no one should go to jail for a mushroom. But more importantly, because more people are going to jail for these other things, no one should go to jail for crack and for meth and for heroin. We need to like provide treatment for people and treat this as a public health crisis. In the way that we would treat, we treat alcohol and tobacco and legal drugs. So there's some nuance there, and thankfully, when I've been interviewed about those things, about those initiatives, they've conveyed, like the New York Times conveyed that nuance to a reasonable degree that I am concerned about, like, that's not the way psychedelics should be developed, and there will be harms if you just like have like cannabis shops the way, like, one can't just visit Denver for the weekend and I don't know, maybe smoke pot and they haven't done that since they were in college and do that. And they're probably going to be fine, not always, but, chances are,
The vast majority of the time, it'll be relatively harmless.
right. Not recommending it, but mushrooms are different. These are extremely powerful. Like you can have an acutely, it can resemble psychosis in some situations. Someone can really depersonalize, really panic. And it's not the typical thing. Most people that use these drugs and, just in the worst of scenarios, a bunch of young guys hanging out together, like they're fine most of the time. Most of the time when you drive your car without a seatbelt, you're going to be fine. So I think about it like that. I have a file folder that grows every year of like cases where like, yeah, just these extreme cases, like these are powerful drugs. Sometimes people do fall from a height, and sometimes whether they jumped and thought they could fly, who knows, but like plenty of people do it on high doses of alcohol, so it shouldn't be a surprise that any intoxicating drug can be associated with those accidents. People, I think of one case in Oregon, a kid loaded on mushrooms, just didn't know what he was doing. He ended up in a neighbor's house and the police ended up shooting him. And just these things can happen, and these are highly salient cases. I mean, back in the 60s, so there's some debate about whether it actually really was the cause, but Art Linkletter in the 60s, his daughter, he was a famous television personality, his daughter jumped out of a window and that was blamed on LSD. There can be, and again, there's some question about what the veracity of that, but in fact, people, whether that happened with her, like people have died from falling or jumping from heights on psychedelics. Not the most typical thing, but these are powerful compounds. And they're, to be clear, if someone hasn't like figured it out now, I'm not encouraging, willy-nilly use of these things. They're best done with these safeguards that we have in these studies. And so I don't know, that's something kind of the most relevant policy issue that it's, we need to also not, I don't know, be so cautious in defending our research that we are afraid to, I kind of feel an ethical responsibility to say, hey, I've been studying drugs and behavioral science for 20 years. And let me tell you what my assessment of like how we should be doing, just as a basic behavior, analysis perspective, like, extreme catastrophic punishments that are highly improbable are really poor ways to try to control problematic behavior. I mean, that's what, and so it's just no surprise that, our approach nuance that, yeah, drugs are also bad. It's, drugs can be bad.
Got it.
And so, but the way to address that is not to cause more problems. Yeah.
Okay. Well, thanks for sharing your thoughts on that. And I appreciate the candor and the willingness to kind of, again, just share your thinking on kind of issues beyond the lab. So let's end with, you kind of teased something in an email to me about your thoughts on this whole, we're gonna get back to like the discounting piece, I suppose. So I wanted to end with this because I think this would be just, I'm really looking forward to your thoughts on this. But you mentioned something to the effect where you think the term impulsivity is and I'm quoting you here, a bankrupt scientific construct.
Yeah.
I want to hear
So,
everything about. So tell me why. Tell me what's wrong with the term impulsivity. Obviously, from a behavior analytic standpoint, it's a construct nonetheless. So we would be skeptical and wary of it, just more generally, and think about ways to define it better. But just in a general sense, what's problematic with that term, and what's a better way to kind of think about it?
Well, again, you're always pointing me in the right directions that I'm already heading. So as a construct, and so I go back to Meal and McCorkindale and Meal 1948 on the, essentially defining what should constitute a hypothetical construct or constitute alternatively an intervening variable. And so the argument I would make is that impulsivity satisfies the criteria for neither. Now, this comes down to the idea that behaviorally we have any number, depending on how you categorize them, of underlying behavioral processes that are fairly well defined and do meet the criteria for a validated construct that hold up. So delay discounting, and I would say more broadly, and there's some work showing that it's closely related to, delay of gratification. And so some work has found that in factor analysis, those tend to move and groove together. Not surprising. They deal with how organisms deal with delayed reward. Um, you can call it a number of things, but response disinhibition. Some people call this action impulsivity, or these are go no go tasks, like the stop signal task, choice. So often at times delayed discounting is called choice, impulsivity. But then you throw in there attention tasks. You can throw in there, you can call it how we deal with probability or risk taking. So whether it's probability discounting or sort of tasks like the BART task, how you deal with probabilistic outcomes. These are all, the research is clear at every level. Every study that's looked at these in terms of behaviorally, they don't correlate well with each other. They, you factor analyze them and they lump into separate categories. In terms of neuroscience, it's well established some of these basic processes have distinct, whether we're talking about the neurotransmitter level or the anatomical region that's involved level. These are different things. Delay discounting is not the same thing as response disinhibition, even if both are aspects of ADHD. And that's another thing. Clinically, we know that they show a different clusters of profiles across different disorders. And so interestingly, I've just described the behavioral side. You can jump to the personality psychology side and see the exact same story that's unfolding, that has unfolded. And in fact, it's been danced around for years that these things, that sort of subscales of various impulsivity scales should aren't pointing to one superordinate construct, and that they shouldn't be added up. In fact, one of the developers of one of the big personality inventories of impulsivity put on a Twitter, "Oh, just a reminder, there is no you shouldn't be using a total score. That's like adding up the big 5 personality traits to come up with a personality score." So a similar story has unfolded on both the personality assessment side of impulsivity and the behavioral side. And my take is that they are, you name the underlying process, be it delay discounting, that's a thing. Here's what we know about that thing. Response disinhibition, that's a thing. Here's what we know about that thing. That everything falls apart when we lump it under this term impulsivity. And I think it's like we've drifted away from this kind of core appreciation for philosophy of science that was there in the early days of behavioral science, where there was this really neat, there was something good that came from the idea of like, hey, behavior can be a natural science. We're going to defend our turf, like this is like rigorous, this is not just like making up terms left and right and slapping labels on things. Which is why, you have this like appreciation for like what really constitutes a hypothetical construct, what constitutes an intervening variable. If we're going to use terms for things that are not directly translatable to the behavior that we're seeing. And so I think impulsivity is one of those things. It's run off the charts. And we're less sensitive to those basic principles related to the philosophy of science now, and we're just so used to, it's like, well, every paper starts with delayed discounting is a form of impulsivity. Is it really? You know, yeah, says who? I mean, the last 10 papers that you read, you know what I mean? It's something that just keeps getting repeated. And another thing, maybe the final thing I'll say on this that I think is interesting, try to find in the literature a single definition of impulsivity encompassing these different areas that is not a string of or statements. Impulsivity is a failure to attend to delay, to future outcomes, or rash action, or insensitivity, jumping the gun, poor risk take. It's like, all no, come up with the definition that's not a string of ors. Come up with the definition that what do all of those things have in common? If you had to say one thing that captures all of them, and the best I can come up with, it's behavior that we find suboptimal. And that's just like really poor. And even that opens up something like, some of these aren't like, they're fundamentally different. Like delayed discounting, I think everyone that really understands it realizes, like, the goal isn't to have as little delayed discounting as possible. There's a whole range of pathologies associated with not discounting enough.
Sure.
Like, yeah, that's not necessarily true for, like, you pretty much want the best response disinhibition as you can. If you need to withhold a prepotent response under a certain situation, like, the lower that reaction time, the better. You know?
When I think about individual differences in delayed discounting too, I always think like, if you look at it at the groups level, and this is, I sometimes wonder what, well, I'll come back to that in a second. I'll come back to the unfinished thought in a second. I have to imagine there's some utility of having a diversity of profiles, whether it's in a tribe or, back in the day, or in a, maybe in an administrative or executive team or something like that. You got to have, there are some people who are, their inclination is to go, and then you've got the people who is like, wait a second, let's think about this, let's think this through. And if you have all in one camp or all in the other camp, both of those are not optimal.
Right.
And if, and I'm not saying that if you put all this, these divergent views in the same room, something optimal is going to come from that. But, I'm just thinking from like an evolutionary standpoint, there's, you can imagine that the super impulse, I'm just using the term impulsive colloquially here, super impulsive people, despite the fact that they probably had a higher likelihood of doing things like, getting killed by making, rash decisions or what have you, that there was utility enough, that they had enough utility to, not get, trampled out of the gene pool, and then vice versa as well. I don't know.
Oh, I totally agree. I mean, I think that's, so many of the, you look at science, it's risk takers that are, that likely ended up making some of the fundamental advances. And then you look at the arts, you look at, business innovations. Like, the person that comes up with the new model in business is not necessarily the person who's best to be the long-standing CEO with the nuts and bolts and the boring stuff of business. Like, you know what I mean? Like, the person that comes up with that disruptive technology does not make them the best person. So there are different people that are good at those things. Like, maybe that person that came up with that disruptive technology needs to move on to another company, invent something else, or a different division of that company, and let the kind of the person who's good at the red tape and the nose to the grindstone, like, let them, run things. And
Yeah.
I think about this with science in the sense that, like, one of my fears is that our selective pressures they aren't the same ones that were at play probably like 30, 40, 50, 100, 200 years ago. I wonder the degree to which our current environment would weed out the Newtons and the Einsteins, and the BF Skinners.
I mean, in the
Like, it
academy?
selects. Yeah, I think it really selects for a bunch of stuff that really doesn't, like, getting grants through committees. Like, it's kind of a process that, like, really weeds out creativity, and just it just it it just this is not how Nobel Prize like level, discoveries are made. I mean, I think that the it selects for, I mean, the amount of paperwork, like I mean, I'm always afraid that like all these things that, there's just every level of like, have you forgotten to cross a T and dot an I, or submit this like annual renewal for like, into just like the level of certifications that it's growing every year. I think science is selecting for people, I'm afraid, who are like really good at that stuff. And I kind of think about this in the evolution within a career too, and something I've always try my best with my trainees with, like, the thing that necessarily gets you to graduate school isn't necessarily sometimes it is, but it's not necessarily the same thing that helps you be a good principal investigator. Like, you can get to grad school and even a postdoc by really just being a really good student, like following orders, making sure something doesn't get forgotten. Some of the best trainees I've had, and I've had them of all type, have been like ADHD type. They're just like, yeah, they're not the one you want to do the last spell, proofreading of the paper, and maybe they would have forgotten this or that, but like, they're highly creative. They generate ideas. You can't have a conversation with them without coming up with a new scientific, a study, idea. And I don't know. I'm afraid that, kind of like with you explaining the different types of people that we need in society and the selective pressure. I'm afraid, and even in science, we're like we're weeding out the people that kind of the deviants who like,
Right. Who don't have the patience for
were
the
more creative. Right,
sure.
right. Like, they get killed by the paperwork or by whatever, and it's just not interesting to them. Like, they're going to go to business or to some other sector.
I see. Yeah. Boy, man, we could probably continue talking about this for a while, and I think I've held you about almost a half hour over what I promised too. So I want to be respectful of your time. So, um, Matt, I just want to thank you so much for joining me. I will, if people want to follow you on Twitter, I'll link your Twitter to the show notes for this episode. If there's other ways in which people can follow what you do, just let me know, and I'll make sure to add that to the show notes as well. Yeah. So
Sounds
just
great.
again,
Yeah.
yeah, this has been a fun conversation. Went in a bunch of different unexpected directions, which is
Right.
is always a good sign. So thanks for joining me today on the podcast.
Yeah, really enjoyed it, Matt, and yeah, my pleasure.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.